So good afternoon, everybody. Thank you for joining us for the monthly webinar. This is the hypertension webinar. We thank you all for joining. This is Lauren Nunley, and we're glad that you all could be here today. If you haven't already, if you would write your name, type your name in the chat box and what facility you represent, just so we can get an idea of who is here with us. So it's just after 2:01 now, and just respectful of your time, we'll go ahead and get started. Katie, would you advance to the next slide, please? If you could all mute your phones, that would really help us with background noise, and then we'll be able to hear the presentation and any discussions a lot more clearly. Also, if you happen to have to leave your phone or leave the conference, please don't put your phone on mute, because as you may know, there's always background music sometimes, and that can be disruptive. So if you have to leave the call, then just go ahead and leave, and then just dial back in when we get ready to start. Please use the chat box for any questions. There will be opportunities to have some questions at the end of the first session. But if you have anything that's burning, you could go ahead and put it in the chat box. Next slide, please, Katie. Okay, so every month we want to just bring up the key driver diagram for this hypertension initiative, and to look at our aim, which is by 12/31/21, to reduce the rate of severe morbidities with women with preeclampsia, eclampsia, or preeclampsia superimposed on pre-existing hypertension, and we want that goal to be reduced by 20% from where we are currently. So I want you to be familiar with this key driver diagram and look at the interventions that we're implementing, and to just become familiar with this and share this with your colleagues and your staff in your facilities. This is what we want to accomplish as an initiative. So please become familiar with it, and if you have any questions or if you have any comments, please do go ahead and ask. Next slide, please, Katie. So again, we're going to look at the hypertension structure measures. These are all the measures that you will report on quarterly. Now, as was mentioned in one of the previous webinars, and most of you may be familiar with this, is that the Joint Commission had some new standards for perinatal safety that will be implemented in July of 2020. I know a lot of the facilities are Joint Commission accredited, some are not, but as a collaborative, we've made a decision that we want to try to align a lot of the AIM standards. Got some background noise, I'm sorry. Could you all make sure your phones are muted? Thank you. So in order to prepare us as a collaborative and prepare the hospitals that are Joint Commission accredited to be in alignment with the standards, as you can see on the screen, there are some elements that have been highlighted. Now, the Joint Commission does require that for hospitals that are accredited and will be held to these standards, that some of the elements will require documentation. That's what I've highlighted here on the screen. You can see on the screen. So for the structure measures, S1 and S2 and S4 are elements that will require documentation. So this is something for you all on the call to become familiar with and to share in your facilities, whether that be with your risk managers or your executive directors or your L&D managers or whoever is responsible in your department for overseeing the Joint Commission process, and also to become aware of that. We will be reaching out to get some ideas from you all as to what you're doing with doing an analysis or some kind of gap analysis in your facilities, and hopefully with sharing that helpful information that we can use in the collaborative. Next slide, please, Katie. So again, we'll look at the process measures, and for the hypertension initiative, again, with the new standards for perinatal safety for the Joint Commission, with the elements that pertain to hypertension, there are two process measures that will require documentation. And as time goes on, we'll have more discussions about this. But the two elements of the hypertension bundle that require documentation are P4 and P5. So for facilities that are implementing hypertension bundle and are Joint Commission accredited, you will need to have documentation to support treatment of hypertension and administration of magnesium sulfate as part of your protocols in your facilities as we approach the accreditation process, as you approach the accreditation process and the requirements for July 2020 for the Joint Commission. Dr. Clarkey, do you have anything to add to that before we move on to the next slide?
Hi, everybody. No, thank you so much. What y'all will notice is that we did change the slides for the structure and the process measures, specifically highlighting the ones that help accomplish and meet the Joint Commission standards. What I think is great for the hospitals that are accredited by Joint Commission, which is a good number of y'all on the phone, participation in GaPQC and participation in the AIM bundles, actually those are very aligned. So this is kind of two birds, one stone type of thing. One of the reasons we wanted to highlight this is that we have heard from some of the conversations we've had with hospitals is, to Lauren's point, that not everybody that's on this call is the same type of team that participates or readies for the Joint Commission process. So if your team is not the team that does that, just to make sure that your hospital system is aware that you as a quality team have already been actively working on these measures, I think will be really important. And to make sure that we're trying to do this to the best of our ability on kind of the central GaPQC side of things, to make sure that whatever documentation we're doing for the collaborative will also help you meet the needs of accreditation. Kind of, again, the not trying to recreate work, but to get the biggest bang for your buck with this work that you are all doing. I will pause and see if there are any questions about that, because I think that this is a really exciting part, but also a really important part for folks to have a chance to dialogue about. Are there any hospitals that have had conversations with their executive leadership or their compliance folks about these new Joint Commission standards?
This is Verita from Northside Hospital Gwinnett. We have had some conversation about it, and also we're working with our quality departments, or they pull all of our data, and just wanting to make sure that we have everything in place. So we're in conversation about it now, though, but started that.
Great. Thanks, Verita.
If there are... Hi, this is Heather from Emory Midtown. We are having conversation about it. We've had it for years. And so now it's finally in our order set. And it's no longer on paper alone. And then we're having it in the quality meetings also with senior leadership. And now every nurse has to attend the drills that we're doing in the quarterly session. Thanks.
That's awesome, Heather. Thanks.
Yeah, it's helpful information.
If folks have other conversations with their quality teams and senior leadership about and have ideas about how they've been able to streamline these things, we would love to hear and share so that all hospitals can benefit from this. And ultimately, it's all hospitals benefit from implementing the bundles, which is some of our goals. But thank you, Rita and Heather, for sharing your thoughts. And if there are any others, we'd love to hear. And if not, Lauren, back to you.
Thank you. Next slide, please, Katie. So again, these are some of the hypertension goals that we have for the collaborative by 2021 to reduce severe maternal morbidity by 20%. And lofty goals are appropriate medical management in under 60 minutes at 100%, debrief on all new severe range hypertension cases, 100%, and discharge education and follow-up within 7 to 10 days for all women with severe range hypertension, 72 hours for women with severe range hypertension on medication. Again, a goal of 100%. And these, we've got time to work on these. I know we're in the very early stages of this initiative, but that is those are our goals currently. They may change, but we want to work with you all to accomplish that. Next slide, Katie. Okay, so some of you may recall from, I think the session 2 months ago, we started talking about a data collection tool in preparation for collecting data for the P4 measure, which is time to treatment. So on screen, you can see a data collection tool, which is adopted from the Illinois Severe Hypertension Initiative. So with the help of some volunteers from this collaborative, this tool was modified for Georgia to provide a tool for hospitals to use to help to collect information for this very measure. Now, this is something that is going to be available for you all to use if you so choose. If you already have a process in place in your facility, whether you're working with your IT system or you've got something built into your EHR, or you've developed a process where you can extract the information that is on this form, we're certainly not asking you to change what you've already done. We'd love to hear your feedback on what's working well for you, but this is a tool that was developed with consensus from members from different facilities across the state that are part of this collaborative. And the elements on there are what we really want to be able to collect for the P4 measure. Now, I wanted to get some feedback from Ginny. Are you on the line?
Yes, I am on the line.
So Ginny,
yes, I'm here.
So I know that you piloted this tool in your facility, and I just wondered if you would be able to give some feedback on what you felt worked well, what some of the challenges were, just so that we can share that among the collaborative, and if there's any questions that anybody has, then we can share them.
Sounds good. Can you still hear me?
I can.
Yeah. Okay. We really struggled with the diagnoses and the adverse outcomes because it's really hard information to obtain because a lot of it is based off of coding, unless we did a full chart review. But still, quite frequently, the physician doesn't always document it the way they should. So that was a tough one for us. Also, we saw that time-wise, it takes a long time to do this form because of how much the nurse has to go into the chart or the auditor has to go into the chart to find the different information. And we really feel like until we can really say that we are improving the repeating of the blood pressure at 15 minutes and then treating within the first hour, we really feel like that more data is going to almost be too much because we're not meeting the first goal yet. And so until we meet that goal, then we feel like pulling more data after that will be important. But to start out with, we really feel like just making sure that the first dose is given within that hour is really where we need to focus. Some of the things like adding the mag sulfate, the race, the location, the gestational age, those sorts of things were great. But it was more the times of the medications, what medications, those sorts of things that we found to be a little more of a struggle.
Thanks for that feedback, Ginny. We've also added, this was some feedback from the maternal committee to add a balancing measure, and that you can see at the bottom of the form, B1. what we want facilities to be aware of throughout all of this process is when you treat patients and you have to administer some IV antihypertensive, you want to make sure that you still are within a safe place for the patient, and to identify whether in an attempt to do good, such as bring down her blood pressure, whether there's an adverse effect from that, such as her becoming hypotensive. So that's why we added that balancing measure at the bottom left-hand side of the screen. We also added on the bottom right-hand side of the screen whether there was debriefing done. And again, that's just another tracking measure. I'm getting some feedback. I'm getting some comments that there's some feedback. I'm just asking if you could all just mute your phones. I'm not sure whether that's coming through because the phone's not muted or whether it's technical problems, but if you haven't already muted your phones, if you could do that. So does anybody have any questions about this tool or any recommendations based on what they're currently doing to look at how they can collect data for this measure?
Lauren, this is Missy. I was hoping to ask just one question. Jenny, thank you for your feedback on actually using the tool. And so hearing that the diagnosis at time of the blood pressure and the adverse maternal outcomes later were difficult in your setting, I think that's really helpful because not everybody has to use the same form. If that's not reasonable in your setting, I think that that's really okay. One question that comes up for me, though, that I'm curious about how you guys did, and then maybe if anyone else has some feedback on this, how did you identify cases? Was that through an electronic medical record search, where you could query the blood pressures, or was it communicated through or from nursing staff, or how did that happen? Could you describe that for us?
I know that we first run a report and identify any blood pressures within the EMR that are within that 160 over 110 or greater range. But then from that point, our nurses go in and look at every single blood pressure to identify whether it was sustained, if it falls out of the measure for any reason. So they really have to do a very, very detailed chart audit, diving into each chart to get the information.
Thank you. Are any other folks not able to do an EMR query for the blood pressures?
This is Deborah. Our blood pressures are going into simplicity, and I don't have the ability to pull those. So, yeah, I don't have the ability to pull that data from our EMR. So I'm questioning how we also find, because it says new onset. How do we find, what's a way to pull out the ones that are just new onset? If anyone has suggestions.
Yeah, we'd love to hear some feedback, particularly from facilities that are not able to do queries in their electronic medical records. And thank you for that question, Deborah. That may be something that we'll have to, as a collaborative, we'll have to continue to get some, dig a little bit deeper and get some feedback, maybe from other states that have been working on the hypertension initiative or from other hospitals. We just had a response in the chat box that one facility has asked pharmacy to pull a list of patients that are receiving the medications. We know that some have done that. That does give some information, but it will only tell you the patients that have been treated who have severe range blood pressures. It doesn't capture those that have severe range blood pressures but weren't treated. So while that is a good place to work with, you probably also need to have some way of being able to identify those with severe ranges. And that is what we would like to hear from you all. If anybody has any recommendations for what they're doing, particularly if they can't get a report built, we'd love to hear from you and love you to share that. Yeah, I'm just looking at some of the responses in the chat box that have to look at the severe range blood pressure to determine acute onset for the measure and exclude patients with a diagnosis of chronic hypertension. That's one aspect. And then Jennifer said that she has to review each patient chart to pull blood pressures and then review when they were treated and with what medication. And I'm sure that that can be quite timely. And that's precisely one of the reasons why we delayed asking for data submission on this measure, because we knew that it would take some time for facilities to figure out how they were going to do that. So it looks as though this is going to be an ongoing discussion and sharing of what people are doing to see what can best work. So this tool was developed as an option. We've got a little bit more tweaking to do, but we'll certainly make it available, and hopefully if you start to use it in your facility, you can give us some feedback as to what's working well, just like we heard today. And this form may need a little bit more tweaking to help to be beneficial to you all. So if there are no more questions or no more comments about this this tool, we'll move on, but we will be continuing this discussion and continue to talk about ways of helping to find ways of collecting data for the P4 measure. So I'm going to introduce our speaker for today. Kathy Brinson is going to speak to us about doing drills in your facilities, high-tech versus low-tech, drills and simulations. So we're really grateful that she's given us some time today to talk to us about this. So just give you a little bit of background. Kathy Brinson's nursing career began as one of those non-traditional nursing students. She was 37 years old when she attained her Associate of Science degree from Dartmouth College, and 47 years old when she completed her BSN. Kathy pursued nursing with a specific purpose of becoming a labor and delivery nurse and take care and try to bestow the type of care that she received when she was in labor with her fourth child. Kathy is now the maternal outreach educator at Phoebe Putney Memorial Hospital and the Regional Perinatal Center for the southeast part of the state. She holds 2 certifications, one in inpatient obstetrics and the other in electronic fetal monitoring from the NCC, and has recently completed requirements to become an advanced life support and obstetrics instructor and an A1 fetal heart monitor instructor trainer. Yeah, well done, Kathy, and thank you for joining us today, and we'll take it over to you.
Thank you so much, and thanks everyone for joining in and doing your part to move the needle in our state. First of all, I have no financial relationships with any of the companies or products I'm about to mention. I do have plenty of opinions. I'm probably not going to offer any of those on this talk, but we're going to take a peek at some things that are available, even if they're figments of your imagination. We'll get more to that in a second. Go ahead. Next slide. Why do drills? The background of this slide is from a consensus statement from ACOG, the National Partnership for Maternal Safety. You know, we've read many different documents telling us how important drills are. You know, we get new people on our unit, and it's really beneficial doing drills when our patients are not at risk of harm. So, you know, doing drills and simulations is virtually risk-free, without liability issues, without harm to patients. So we probably, well, at least some of us have been working long enough to know that when we would orient new people to a unit, we wanted all the complicated patients so they get firsthand experience. Now we have ability to do some training and some teaching without that liability. Another thing, even with our patients, you know, there's competition on the unit. As labor and delivery nurses, invariably, especially night shift, you might deliver a baby And there's some competition on residents, OB residents, family practice residents, midwifery students, to let that nurse actually get the hands-on experience. So, drills and simulations allow that at least next to the best thing we can do. So, there's high-tech, there's low-tech, and I would say no tech, but, technology itself has to do with putting our knowledge into practice. So, next slide. Okay, here's one of the products, high-tech, Victoria by Gomard. Advertisement for this machine says it, to meet Victoria, the world's most lifelike childbirth simulator, more than realistic, exceptionally lifelike and anatomically accurate. She cost a lot of money. Fortunately, we don't need high-tech instruments to do the drills and simulations that we have. I just thought I'd put a picture of up here, and in my southwest part of the state, where I know Kelly and Ravanna are on the call. Maybe some others joined a little bit later, but pros and cons to this thing. The con, it's very expensive, takes a lot of money, and we do have rural hospitals trying to keep the doors open. A high-tech instrument like this is not a high priority. There's a learning curve with these instruments also, but she's fairly realistic. She's got lots of bells and whistles, which do seem to draw attention or attract learners to want to be a part of drills when you've got some kind of machine like this. Next slide, please. To be fair, in the competition in the market, Laerdal is another company that makes high-tech simulators. SimMom is Laerdal's counterpart, and again, a lot of money. Pros and cons. There's a lot to say about what we can do with these high-tech instruments, but we don't do anything with these high-tech instruments that we can't. We have to set up the drills and simulations by starting on a piece of paper in our mind with what's going to happen, even with these high-tech things. Let's go ahead to the next slide. A little bit lower tech, there's this instrument called Mama Natalie, and I know several of the hospitals in my perinatal region, Region 6 down here, has this Mama Natalie by Laerdal. This is it's kind of like a backpack, except you wear it on the front. It's got a baby inside, and the person who is wearing this model can actually respond like a live patient, and can either, deliver that baby, let it come out, or not, can let it bleed. Moms can even fake seizures and such. So, this is not quite as high-tech. It's less than $1,000. They won't give you a quote unless you're really interested in buying it. So you'll have to get in touch with them if you're interested, but it does serve the purpose of simulations or drills that we need to do, or I've used it in several places. It's basically as real as whoever's wearing it to me. I like her. Next slide. Low tech, low cost, there is this thing called an SP. Have you ever heard of standardized patients, the SP? Using real people. This really does require some imagination. Bet you could, if I asked any one of you 77 folks on the call, is there someone you work with or in your department who is a real ham or a real actor or who really likes to be the center of attention? You've got your model. You've got your person who can sit in and pretend to be our postpartum mom with a hypertensive crisis, or any of these situations that we want to practice or have that simulation or drill for. If you don't have a staffer interested in it, playing the part, maybe a friend or a family member who you could pull in. You can still do hemorrhage and seizure drills with a real person, just so that they know. It's helpful if they've been in the OB world because they know how patients have previously responded. There are tools that we can use with a real person or an SP, standardized patient, to help enhance the reality or the realism involved with it. There are visual cues for the vital signs, and I think, well, it's in another slide. We'll look at that in just a second. But when we use real people, it does, add that human element to the simulation. And some conversations that you can have with a real person that you can't even pull up in the highest tech, most expensive simulator there is out there. Let's see. As long as that person who's playing the part knows what the critical triggers are and can behave like we might see our patients behave. Go ahead to the next slide, please. Thanks. Okay. I don't think Judy is in one of the hospitals in our region, and we just recently did some drills down there, and I got permission to put her on a slide, but I didn't have any consent for the real person, the standardized patient that's face is covered up in this picture. One thing we do need to consider if we get people in the role is whether or not we should get consent for them to be photographed. So some hospitals, most marketing places do have a written consent if you're going to take pictures. Another thing is, these big high-tech models, Victoria and SimMom, have a component of videotaping, or it's not taping, but videoing the event so that you can go back and debrief. But you don't even need that. Everyone that I have encountered recently has a cell phone with the ability to record or video. So really, if you've got consent of the participants, putting a cell phone in a strategic place to video may work for the benefit of that debrief. If you can't get anybody to volunteer, I guess I put do it for the mamas on here. If you can't find any one of your staffers to do it, you can do it, and do it for the mamas. Next slide, please. The proof of how well drills or simulations work is in the pudding. There is literature telling us we don't need high fidelity or high-tech models to do simulations and drills, and I guess that's where I want to be the cheerleader here. You don't need to have all these high-tech things. Next slide. You don't have to say now, or we'll wait till the end, but give me some examples of low-tech tools that you use. We can do hypertensive crisis drills not just in labor and delivery. It can be in any part of the hospital where we might need to go. It might be our antepartum unit or postpartum unit, even the triage in your L&D or the emergency department. I recently went in one of our little rural hospitals and did drills in the emergency department with the Mama Natalie, the low tech. Let's see. Is it the next? Yeah, next slide. If you look on the right side of this slide, those are 5x7 cards and have that standardized patient, the person playing the part, or the observer in the background with cards already written with vital signs on them in order of how the drill goes. You write up the scenario, write up how the drill goes, and when someone says, well, take her blood pressure, you pull up the next card, and it can vary whatever scenario you want to make. Whatever situation you want to present, you can do it. You don't have to have the monitor that travels around that's so expensive. You can use these cards to relay vital signs. Of course, you need to plan ahead of time with the script for that standardized patient to let them know what is going to happen. And if anyone has never shaken like you're seasoned, maybe in the privacy of your own office or home, see how well you might be able to emulate a seizure. And anyone who's seen one might be able to do it. It's, I think, individual for every patient that we've ever had. But when you get a blood pressure up there, 212 over 107, flip that up, and we don't act on it, then, the drill can present without the high-tech material. The left side of this slide is more for hypertension. I have used expired Foley catheter bags with that tubing and put fake blood in them and had my person hold it under the gown to bleed out when I didn't have any other thing to use. So, there are ways, if you can imagine it, there are ways to conduct drills and simulations without the high-tech equipment. Next slide. And I'm not going to stand on this one a long time. You can go to the internet and get all kind of recipes for fake blood. I know that softy clear hair gel makes really good clots. And another thing, going to the blood bank and asking for them to save expired blood for you makes it a little more realistic. Or if you can get empty bags from them to spike into, if you get a expired or a left-out bag of Ringers or saline or something and then put the blood dye in it, you can spike that with the blood bag and fill it up. There are easy ways to make all the items you need for the simulations. Next slide. Even fetal heart tones could be simulated in a low-tech drill. This paper that's in the background of this slide says how you could draw whatever strip you want and feed it into the machine where you're going to be doing the drills in the labor room. You know how fast that paper moves, and you can work the timing out to have the drills happen with the corresponding paper strip that comes out. You can have a standardized patient, tapping out on something hard the rate of the fetal heart tones. Another helpful thing may be to put that standardized patient or the person playing the role, or even any one you're using for the simulations, have them added to that. Here we call it the test record in the EMR. Some places call it in the electronic medical record playground. Not in a live field, but if you include the patients in the test background, even practicing or simulating documentation is helpful, just putting them in the background on the test. Next slide. Okay, what have I learned in the time that I have been trying to conduct the drills and simulations? Plan out the objectives. Really, what is it you want to accomplish? Write it down. What are we doing here today? Why are we doing this? What are we doing it for? Maybe recognize signs and symptoms of a hypertensive crisis, or just be sure to plan the objectives. Another thing, be willing to accept feedback. Now, feedback and there's a difference in feedback and debriefing. You go to a debrief, and I think the last month we had a really good presentation on debriefing. So I'm not going to talk about that in too much detail. But debriefing, feedback is different, because if you don't get the feedback, you might not be addressing mistakes that have happened. It's good to be able to willingly accept feedback and take critical information and use that to better the next drill. Do conduct the debrief when all is done, and let the staff know what's expected. I've gone into drills before just kind of like off the cuff, and not even the staff in the hospital where I'm thinking of a particular place now was like, well, we didn't know we were supposed to really do this. Up front to have a spiel about this is what the plan is, this is what we're going to do, you're going to get a scenario, we're going to treat this patient, do everything you can do, and if it were a real patient, and by the way, if it is a standardized patient, a real person playing the part, be sure there's instruction on, you don't want to give them that hypodermic. You squirt the med in a receptacle there at the bedside, or say out loud what we're doing. I'm hitting the call light. I'm asking for an IV start kit and the hemorrhage card, or I'm asking for mag bolus to be brought in the room. If they say out loud what they would expect to do, it is helpful for the observer and everyone in that drill to know what's going on. So if you let the staff know what's expected ahead of time, they're not wondering, is this real? How real do I get here? Oh, we really have to run to the blood bank? So instructions ahead of time, I think, are very helpful. Some people like to do a survey before the drill, like a 5-point Likert scale or something after the drills for comparison, was the drill helpful for them? That kind of thing, I suppose. Next slide. You may have all seen this before. All these plates are flipped upside down except one. When you see that one, then you'll see all the others flip up right. I don't know if y'all have seen that. I pulled that right off Facebook, and the reason I stuck this at the end of this, because whenever we're observing, we've got to be open-minded and not get stuck in what we think is the way that things have to be done without any input. We have to be willing to hear other people communicate well, hear what they're saying without taking offense, and know that we are all pointing toward the right direction. We all want our moms, our babies, to get the safest, best care in the state. We all want that for our people. So, being willing to see things from a different perspective may help us reach that goal together. I think, next slide. Thank you. Thank you all for hearing me. Please feel free to give feedback and especially give tips and suggestions that you have had that you feel have made your drills or simulations run well, especially if they're the low-tech ones, because I think, I'm in South Georgia, so we've got a lot of rural territory down here, and I don't know if I can assume that it's less likely that every one of my hospitals is going to have a $100,000 birthing simulator to be able to conduct them. Another thing, on the weekend night shift, it's a lot easier to run a drill when it's a good time to do it, when the staff says, we don't have but a couple patients or one patient. Maybe it's a good time to, drill each other or do a simulation here together. Anyway, any suggestions or comments or communication with me, I covet it. I would really appreciate it. I know that a few years ago, Dr. Ellis at Grady sent to all the emergency departments in the state the eclampsia algorithm, the evaluation and treatment of antepartum and postpartum preeclampsia and eclampsia in the emergency departments. So running drills, even though you are OB or labor and delivery or postpartum, maybe call up the emergency department manager or educator, if there is one, and say, hey, look, this is what's going on with our moms in the state, and help them to recognize, that preeclampsia, or if they're coming in seizing, it may be eclampsia. So it's good to be able to communicate with all the departments where our moms may come back in or where they are staying while they're here. So I think that's all I've got. But please do, chat box or email me or call me if there's anything you'd like to add or help me be better. How about that?
Thank you, Kathy. I will open the floor for any questions or, as Kathy said, any recommendations or suggestions or sharing of what you might do in your facility, particularly if it's low tech, where as Kathy said, some of those simulators can be really very expensive, and we don't expect that everybody's going to have one of those. But if you do have any great stories or any great recommendations that you would like to share on this call, this would be helpful to everybody listening.
Hey, Lauren, this is Jenny. I have one thing to add when it comes to simulation. So we have, because I'm at Northside Atlanta, and we have a fantastic simulation center, and we have Victoria. So we've used her, but we have started this year doing interdisciplinary hemorrhage simulation. And the first part of the scenario is where the nurses are recognizing the deteriorating patient. And from what we have learned from doing it, we are not using Victoria for the first part of the scenario because it's much more realistic for the nurse to talk to somebody in the bed who's saying, oh, I'm in pain,
Okay.
no, I'm 35 weeks pregnant. So really we decided to go low tech with part of it because it was better. It gives us a better simulation for that part of our simulation than you trying to use Victoria, who, when the nurse says, are you in pain? And then the Victoria waits 5 seconds and then goes, yes. You know, that's not very realistic to the nurses. And so, so just as an encouragement, we are using both because we have seen how important the realism of having a person pretending to be the patient and part of it. But when they're in the OR, you never talk to the patient anyway. It's different when it comes to using the mannequin or a higher tech device.
That's really great sharing, Ginny. I appreciate that because I actually never considered that using both low tech and using a standardized person, as Kathy calls it, in conjunction with a simulator can really be beneficial. Thanks for sharing. Does anyone else have any other anything else to share or any other comments to add? And while we're waiting for some feedback, Kathy, I did want to ask a question. You mentioned about videoing and using, perhaps using the cell phone. Can you tell us how helpful it is to video these drills or simulations and what staff can benefit from looking back at what they've done?
Okay. Big confession. I have never done it, and I have the technology to do it.
Okay.
But I know it is done with the NRP. Mindy, I share an office with. She videos for the NRP hands-on part, and I really am going to do it, y'all. And here's the benefit to me. Sometimes in the moment we don't see or remember what we did. You know, it could be valuable in having the debrief to say how well everything went. How did we do that? Wow. How did we get her to the OR in less than 4 minutes? How did everything go together so well? You know? Or and to have a video to go back, it would just confirm the teamwork that goes on in labor and delivery. It could be, though, the video may show, well, you know, why was I standing in the corner scared to death when I should have been at least, you know, whatever. So I think being able to take a second look when you're not in the moment may help us, you know, not be so reticent next time to jump in and help, maybe.
Hey, I'll add one other thing to that. Another part of the video, the nurse, when you're in a simulation, you're thinking about what you're doing. That's your job. You know, what are you doing? And you don't see the big picture.
Right.
So when you are able to go back and watch the video and see, oh, look, I was doing this, but the person across the room was doing the same thing, and I didn't know it. That's always very helpful, too.
Yeah. Good point.
Great. Thank you.
Hi, this is Heather from Emory again. Kathy, thank you for sharing that. That was so good. And I like what you said about the person being there. And we do have a drill team, and it's a multidisciplinary team. So we have a physician, and we have nurses, and we also have a tech. And we actually utilize one of our nurses. She's such a great actress. So she knows all the scenarios to pull out, and we discuss it and we plan it. And we actually test them. We actually do a pre-test before the drill is even done, and we do a post-test to see where they're increased their knowledge gap. And then we also ask for criticism. We ask them, what can we do better? Because we get so much details from them. So we don't have the Emory does have those models, but we don't have an L&D, so we utilize our people, and we run it in different areas. So That's how we do it. But thank you so much for sharing.
Thank you, Heather. That's really helpful because I had a question in my own head about multidisciplinary drills. Now, you say you do them with physicians, with techs, with nurses in Emory. How have you managed, or how has the facility managed to get those disciplines to work together for these drills? Because that's what's happening in real life. You've got all of those players together. So in an ideal world, multidisciplinary drills would take place in every facility, wouldn't it?
Mm-hmm. Exactly. And we even have midwives come in. So we go in the daytime and we tell them it's going to be a drill. And we plan and say, please don't low census anyone. And we pull nurses out at different times, and we run it in a setting. And we have everyone just run the scene together as a small set. So we do it from like 7 a.m. to 3:30, and we have different sets come through. And that's what we do. And we're trying to get more physicians because we have a special mix where we have, how can I say it? We have Emory physicians, we have community physicians, and we have PMG physicians, and we have midwives. So we have to make sure everyone's on the same page when there is a hemorrhage, if there is a shoulder stocia, if there's a maternal code. So all these things, and of course, hypertension crisis. So we're trying to make sure that everyone knows how to react in this drill. So in the real life, we've got it.
That's great. How are you able to, is it mandatory for the midwives and the physicians, or is it just certain ones that like to play that will participate?
Well, we're making, so since TJC has made it mandatory for the hemorrhage and the hypertension, our new specialty director has made it mandatory for all the nurses, so they need to now find themselves there. We're still having some physicians that we won't see, so we're trying to continue to encourage them to come in, and we just more or less say spontaneously, come on to drill. So it's not hardwired for them, but the residents, they do get to go through it because they're there all the time.
That's great.
It's a work in progress. It's a major work in progress. Yeah. But thank you.
Great. Yeah, no, thank you for sharing.
You're welcome.
Anybody else have any other comments or want to share anything? Okay, thank you again, Kathy. Thank you so much for sharing. Thank you for offering some really great information about how drills can be done in any kind of format. We really appreciate that. And as you all know, we will share these slides and share Kathy's information if you want to reach out to her for additional information. Thanks, Kathy. Next slide, please. Dr. Kottke, do you want to take the wheel?
Sure. This is just a reminder quickly from our last couple of meetings. As you'll remember, one of the goals that we have in our mission and vision is to work on maternal morbidity and mortality through an equity lens. And we had an amazing group of folks from the collaborative work on recommendations about how we might best do that. And implicit bias training for medical providers and nurses was one of the very first things that was recommended. These are, so that's added to our process measures. These are a few resources that for you all to explore, and we just wanted to keep you to let you know that we're, as a GaPQC collaborative, we'll be looking at other options to support the statewide initiative and get implicit bias training to all folks who are impacting maternal health care. And so things like Train the Trainer, online training, and then we're hopeful also to have some training on implicit bias at our annual meeting coming up in April. We just wanted to make sure that y'all had access to some of these if you wanted to start to explore it now. Oh, this is exciting. This is as of yesterday, I do believe, we have Laura Lane has joined us, now taking in a lead role for all GaPQC initiatives. So a little bit about Laura. For the past 4.5 years, she served as the Deputy Chief Nurse responsible for quality improvement at the Office of Nursing at Georgia at DPH. She has a Lean Six Sigma Green Belt certification and leads the integration of continuous QI principles and strategies in the department and throughout public health nursing in Georgia. She promotes a culture of quality and builds capacity to translate QI into practice and improve care and outcomes for Georgians. She is highly qualified for this position. I could go through her educational background, but I'm going to choose not to in the interest of time. But we're super excited to have her join the team, and just thanks so much to the team that we've had that has kept things going. But I think it's really exciting that Laura will be able to join us, and we can do even more. So welcome, and she'll be with us starting. She may be listening right now, but she'll be starting with us on our next call. And then this is very exciting. Our annual meeting will be April 23rd through 24th. We have secured a location here in Atlanta. That's as much information as I know about that.
Yeah, and we are working on getting that information out to you, and but we wanted you to be able to save the date, because for those of you that were in attendance last year, we know that it was a great event, and we hope to match that again in the third annual meeting. So please make a note of the date. More details to follow. We are approaching the top of the hour. If anybody has any additional questions for us now, we can go ahead and answer them, or any comments or anything that they would like to share. And if not, if you don't want to do it on this platform, you are very welcome to email any of us, myself, Dr. Kottke, or Diane, and we will share Laura's information also. So we want to thank you for all that you're doing on these initiatives and in your facilities, and thank you for your time on this call today. We look forward to speaking to you next month. So thank you all for your time.
Happy holidays all.
Thank you.
Merry Christmas. Merry Christmas. Thank you.
Thank you.